So the next case is a patient 60 years old with a pancreatic cancer 1 year ago. He underwent Whipper resection with hepatic artery injury during surgery. Afterwards, right biliary duct ischemia with liver abscess. And now hospitalization for cholangitis and jaundice. Probably with a bilioenteric anastomotic structure. So the first step will be US to exclude relapse. And the second step will be the biliary drainage, either transgastric or percutaneous drainage. This is the MRI of the patient. On the left side, you can see the abscess on the right liver. On the right side, you can see the dilation of the left biliary tract. We should remind small studies, recent studies, who show there was no difference between the complication rates between percutaneous drainage and drainage by EUS. And now let's go to the room with the operators, Dr. Boris and Dr. Say.
So in this patient, we're curious to see if the biliary obstruction is purely due to the progression of this ischemic stricture, or anyway, due to ischemic damage to the bile ducts versus a recurrence. He is 1 year out from his surgery, so it would be a reasonable time to expect a recurrence as well. So as I go in, the first thing I want to do again is look at his liver to see if there's any signs of liver metastasis. I don't see any signs of liver metastasis. And then I'm going to focus on the hilum of the liver. And one of the advantages of this system is that the penetration here is so good that in patients, for example, who have had antrectomy, you can still often see the head of the pancreas from the stomach. And it's also a good position for the patients. Well, these patients are completely sedated, but people with conscious sedation, it's a position where the scope is straight, so it's quite comfortable for the patients. And you can really, from this one position, which is really a central position, you can see the hilum of the liver. When you torque, here's the portal vein. I have to torque quite a lot though because he's on his back. You should be able to see the pancreas, which is above the portal vein. Okay, and this patient doesn't have a head of pancreas. Remember, he had a Whipple. But from this position, usually you can still see also the head of the pancreas down here. But it's also, for investigating the hilum, there's two places to go. One is in the bulb, and if you're in the bulb, you'll generally see this side of the hilum. But for nodes on either side, it gives you access to both sides of the hilum. So for patients who have nodes here, this is a great position to do biopsy of hilar nodes. So as I look at his liver, you can use a Doppler if you want, but this is the biliary system here. And I'm going to just slowly trace it to the hilum. I think you can turn it off. You know, I actually, once you identify the structures, I don't like to keep the Doppler on because it really slows down the image and it can be quite distracting. So once I know that this is the biliary structure and this is the vascular structure, now I'll just focus on this and slowly torque, and I'm looking to where it disappears to see if there's a mass. So in some patients, when you see signs of what I call malignant obstruction, biliary obstruction or pancreatic duct obstruction, in some cases you don't really see a mass, and if you're looking to do FNA, the best place, in my opinion, I don't know what you think, Erwan, is to go where the strictures are. So really follow the ducts to where the strictures are, okay? And I'm looking right where it disappears, and in this area, I really don't see a mass. I don't see any lymph nodes. There's maybe one very small lymph node here, which really doesn't look suspicious to me. But basically, as I interrogate this area, I don't see anything that suggests cancer.
Here is the afferent loop here. And when I change a little bit the probe, we will see here the biliary convergence, where here the left duct and here the right duct. So we have seen on the MRIs I have no separation of the left and the right lobe, so my plan is to place only one internal external drainage to treat the jaundice and the cholestasis. And I prefer in this case, we can discuss, to puncture the left lobe, even if it's a very small left lobe, because to avoid to pass through the right liver abscess. But you can discuss about the strategy. But I've shown this way. So you can see here the left biliary duct with some hyperechoic spot inside. Probably it is air or debris inside the biliary duct. And so I will try to find a window to pass through the left lobe, here at the deeply in the left lobe, and to puncture inside the liver. I don't know if you see the tip of the needle. And we try to puncture and to enter into the left biliary duct, avoiding to pass through. There are two different techniques for PTC, or to puncture only on radiology guidance, or to combine fluoroscopy and transabdominal ultrasound to place the needle. So is the biliary duct. Okay.
And you show nicely how important it is to come a little bit from the left side, because then if you puncture too much in the middle, then you are going in the other direction, and to reach the anastomose would become difficult.
Copy.
There you can obviously turn
So
to the right.
I use a Shiba needle. Scopy. A Shiba needle. Copy. Okay, that's nice. Better. So I'm not in. But it's not a big problem that. I will try to go deeply to a better rigidity of the, because the distal part of this guide wire is very soft, but the body is harder, and so I want to have more rigidity to push the catheter. So I will try to change the axis, but probably I have the side branch, a small side branch, but probably it's enough. Yes, we have to move. So move, and I will try to go in the good direction. Now. Thank you. Using the second puncture, I have the possibility to push the catheter inside and deeply in the intrahepatic duct. Very often, the difficulty when we puncture the left lobe is to, especially after surgery, to have a mobile left lobe. It's sometimes difficult. Moreover, if you use a small guide wire to go inside deeply with the catheter, so I have some difficulties and need to push a little more to go inside. So I will show you, copy, the cholangiography, the cholangiogram, and you see the structure and the small bowel we have seen just before.
There is material inside the right lobe and the right
It's a typical aspect of biliary duct after with ischemia.
Ischemia.
And at the lower part of the image, we have the. Thank you. Okay. We will show just before. Tu peux me remettre l'image avant? Non. Non, ça c'est pas grave, c'est pas grave. Copy. We can. I want to try to show you the small bowel. You see the movement at the lower part. I cannot indicate you with a marker on the fluoroscopy, but maybe it's like that. Scopy.
Sometimes, I'm sure that it will not be the case with everyone now, but sometimes in a very hugely dilated duct, when you place the external drain, you are not able to pass a tight structure.
Yes.
So the trick in this case is just to leave an external drain and to leave the drain in drainage for 2 days, and then when you come back, the bioducts are much smaller and it becomes much easier to pass through.
Hop, no. Yes, I'm lucky man. So because I believe I'm inside, but I completely agree. It is also my strategy in case of failure to pass the structure. If you have a huge biliary duct, to place external drainage and to come back 3 or 1 weeks after to try again. Very often it's more easier at the second attempt.
Probably you have to combine a direct drainage of this
Yes,
abscess.
yes, I will perform just after. It's a I organize that. Tu peux revenir au centre? So I push the guide wire, the catheter, sorry, along the side the guide wire to place. Here you see the mark, the black marker. It's the upper part of the side hole. So I will remove the. So here I place all the side hole inside the afferent loop, copy, and I remove the catheter, the internal catheter, and the guide wire, and I will inject slowly and pull to have a better visualization of the anastomosis, and pulling slowly until I have a good cholangiography on the left lobe and to place guide wire on both sides of the anastomosis. Yeah. The aim is to avoid, of course, to let side hole outside the lever. So I have to be careful because previously I puncture very close to the hilum, so I have to wait. Okay, I believe it's enough. And I can fix the drain.